All right, good morning, everybody. It's 8 o'clock. GIM Grand Rounds is back. We have Dr. Hilary Lum here with us today, who's Associate Professor of Medicine in the Division of Geriatrics. Dr. Lum went to college at Northwestern Med School at Wisconsin-Madison, did her internal medicine residency at Pittsburgh, and then came here for fellowships in both palliative medicine as well as geriatric medicine. And she's speaking with us today about helping to manage patients who are experiencing dementia and trying to optimize their care, which is a very challenging area that we all face with some of our patients from time to time. So very much looking forward to this. Dr. Lum, thank you for being here. Appreciate it.
Thank you for the invite. It sounds like the microphone is on. I am really grateful to be here. I consider you all to be friends, colleagues, and mentors. I first came to the University of Colorado in 2011 and have done primarily research since 2013 and joining the faculty. I'm practicing in seniors clinic 1/2 day a week. And over the course of my career, over the past 5 or so years especially, I've transitioned more into dementia care. So I look forward to our conversation today. I have no conflicts of interest to disclose. These are some of the different funding sources that have funded our work, and I'll highlight the projects that we've been able to explore and even implement into practice here. Part of my goal in preparing this talk has been to be as practical as I can be to what we're doing here at UC Health and what might be helpful in your practice in primary care, busy academic practices. This is Minnie from our team. We have the opportunity to work directly with individuals living with dementia and their care partners. And so much of that is really hands-on. And these are terrific people that have just daily shown up to be compassionate, patient, and really modeling to me the opportunities that we have to support care partners. And it's really gratifying work because as we're present, we hear back from care partners that our work, our care helps. Certainly the gap is clear. We know that dementia care is hard for a number of reasons. We could spend this entire hour talking about how dementia care and caregiver support is hard. I wanted to just add some framing. One of the reasons it's hard is because of competing medical conditions. You're already working on heart failure, diabetes, COPD, end-stage liver, end-stage renal, and dementia may not even make your problem list. So hopefully we'll think through how attention to dementia may be actually value add because the coordinating benefit for then setting up a plan. If you don't know that dementia is present, it makes it hard to support the patient and their family in following through in complex situations. We'll talk a little bit about dementia and the challenges of diagnosing in primary care practices. I think some of the barrier for primary care diagnosis of dementia can sometimes come to our perspective of limited knowledge of resources, of current treatments, of available referrals. So we can have a discussion about that, and I'll highlight some of the pathways that I think are a starting place for us. Certainly from a family and patient perspective, there's a lot of stigma related to talking about subjective cognitive decline or memory changes or dementia. And one reason dementia might not be on your problem list is actually because you know from an open notes perspective, individuals are seeing their problem list, and that may result in many more conversations if dementia is on the problem list. And that can be a barrier. Certainly time intensive. And we'll also talk about how dementia as a serious illness, perhaps more so than other serious illnesses, necessitates care partner engagement over the course of the illness. With all that we know that's hard, I also want us to have an opportunity to think about imagining what would a dementia-friendly health system look like, and in particular, what could it look like from our primary care perspective. So some of our work and the way I've organized this talk, these are sort of updated learning objectives, is a dementia-friendly health system could be a place where we could improve brain health and reduce dementia risk factors. I think we are on the front line of that in primary care. We could increase early detection and diagnosis. We can improve quality of care, including aligning with what matters once a dementia diagnosis is known. We could increase supportive engagement of family care partners, not just a sense of overwhelm, you need to do more, but figuring out how can we support care partners. And ultimately, hopefully we can increase connection to community resources, including social prescribing. I'll put in a plug, March 7th in Geriatrics Grand Rounds and some other community events. We have a MacArthur Fellow coming from University of Wisconsin-Milwaukee who has really thought about how we can ask beautiful questions, create beautiful spaces, and social prescribing as a means of connecting with arts and music and other sort of creative outlets and organizations, especially around dementia care and memory cafes as an example. So I'll transition into a very few number of background slides, also to highlight some of the efforts that are happening across our state with our Colorado State Plan. So focusing especially on the right, we know that there are many different types of dementia. And I think our challenge in primary care is to think about when the progressive change in memory is now affecting function such that there is early dementia. We're no longer in subjective cognitive decline, mild cognitive impairment, or cognitive impairment related to other reversible causes that I think in general, we are good at identifying what we hope is reversible, focusing on that. And then it's having that next step conversation of, actually, I think what we're seeing here is changes in your brain that are reflective of a brain disease. And therefore, we should think about what that means for your quality of life and how we can support and understand your needs at home and think about care planning. Age is the #1 risk factor. I'm showing a few Colorado demographics here. So currently in 2023, there are 880,000 individuals in Colorado. And of that, 76,000 have a diagnosis of dementia. We anticipate in the next few years that 76,000 number of Coloradans will grow. And ultimately, our total population will be 1.7 million individuals over age 65 in Colorado, of which a substantial population will have cognitive impairment or dementia. Importantly, there are significant racial disparities in both the diagnosis of dementia, experience of dementia, and access to resources. I'm sharing here some of the what's known for older Black Americans, Latino Americans, and the American Indian and Alaska Natives. The data from the American Indian and Alaska Native population is from our Center of American Indian Health here on campus. And these differences are due to historic and ongoing marginalization. So I think the relevance to us in primary care is, as we're thinking about, is dementia present, even thinking about potentially our implicit biases, am I less likely to see dementia as I'm taking care of and thinking through social determinants of health and other current health disparities that are at present. Talked a lot about individuals with dementia. It's also National Family Caregivers Month. That's November. And so this is what President Joe Biden said, and happy election day also to us. Submit your ballots if you haven't already put them in the mail. President Biden said, during National Family Caregivers Month, we recognize the love and sacrifice of more than 50 million Americans, providing crucial care and medical assistance to parents, children, siblings, and other loved ones, ensuring their health and dignity. So I think, as many of us also know, there is no sort of obvious place and pathway within our health system to readily identify care partners and caregivers. And so I hope that much of the emphasis of my talk will be on how we can identify care partners, what they're doing, and how they can support and be supported. So who are dementia care partners? You've probably already heard me use care partners and caregivers somewhat interchangeably. Caregivers is sort of more recognized and nationally known and has been present in the research. And then also, as we do focus groups and talk one-on-one with people, individuals who are supporting someone with dementia may not identify as a caregiver. They may be informal, unpaid, usually family or friends, may live locally or at a distance, may help in a variety of ways. I think a key point for us from a primary care perspective is naming and valuing the important role that the care partner is playing opens up that discussion and is supportive to them. It helps you build rapport, helps you express that you see them, including in how hard this is. This is my mom, she's 72. She told me in 2018 that she noticed that she was having word finding difficulties. She was 67 at that time. I asked her if she had talked with her doctor about it, and she said yes. So I was glad that she was bringing it up. COVID really unveiled her memory challenges. She was diagnosed with mild cognitive impairment 2021. We saw a lot of progression in the context of isolation. Thankfully, things have stabilized, though at this point, her dementia is moderate. And I think externally, people give me feedback like, oh, your mom seems to be doing great. Like, I can't even tell. And I think that's what's also very tricky in primary care, is that only from perhaps the input from someone who sees them well, closely knows them well, can really tell you, like, what are the differences we're seeing in function. A little bit about care partners from an epidemiologic perspective. Care partners of individuals with dementia are probably going to be doing it for a long time. On average, a person with Alzheimer's lives 4 to 8 years after diagnosis, and we all know individuals who have lived more than 20 years after diagnosis. So it could really be quite a long time, and it will change over time. And the older adults with dementia are more likely to need help, as we know. Here in Colorado, in 2020, there were 160,000 caregivers. That's broadly speaking, not specific to dementia. And carers of individuals with dementia reported higher chronic conditions, depression, financial strain, isolation. So also in primary care, you are often taking care of someone who is the primary care support person of someone with dementia. You're their doctor. You may not even know that they're involved in dementia caregiving unless you ask. 1 in 3 caregivers of someone with dementia has stated that their health has gotten worse in the past year. So just a brief slide from a Colorado perspective. We do have a Colorado ADRD state plan. I've put the QR code here if you'd like to learn more. There are a handful of us across campus who are involved in this statewide convening that's funded by the CDC to work together to try to improve how we can engage the public with education about dementia, how we can develop policies and build partnerships that support ultimately a dementia-friendly state, assuring a competent workforce, which is the work group that I'm most aligned with, and then monitoring and evaluating our changes over time as a state. It's a 5-year project, and if you have any questions, would love to chat about it. So now I want to walk through sort of this imagining a dementia learning health system, trying to think about tangibly and practically what could each of us, as a takeaway point, choose to work on. So there are several opportunities to reduce dementia risk factors. I've listed out here the evidence for various risk factors that really exist across the lifespan. Thinking about avoiding to the extent possible traumatic brain injury, thinking about reducing use of tobacco and alcohol, especially in the context of chronic disease management, focusing on cardiovascular health. All the efforts that you're already doing from a cardiovascular perspective also ultimately help with brain health. So I think that makes it more actionable for us in primary care. Also focusing on improving sleep is important in diagnosing sleep disorders, and then encouraging healthy diet and cognitive stimulation. Just wanted to present one slide tangibly about the evidence for addressing high blood pressure. On the right-hand side are shown the various cardiovascular risk factors and prevalence in age-adjusted ways, and hypertension is very common, as we all know. the data from the SPRINT MIND trial have given us evidence that aggressive control of blood pressure to a blood pressure less than 120 did show decreased development of mild cognitive impairment compared to a goal of 140. So that's one piece of data that individuals, in their 40s, 50s, as they have high blood pressure, in this case, the study participants were 50 and older, thinking about aggressive control of blood pressure to try to decrease the development of MCI. Why does that matter? There's approximately a 15% conversion rate from MCI to dementia every year for someone. So if someone is diagnosed with MCI in their 60s, there's a high likelihood of converting to dementia. And so anything that we can do, including prevention of stroke and management of high blood pressure once someone already has MCI, is important to try to prevent progression to dementia. So I just also wanted to highlight, as we transition into early detection and diagnosis, I wonder if any of your patients are coming in with subjective cognitive concern because they have interest in the anti-amyloid treatments. In seniors clinic, we're seeing that a little bit. The anti-amyloid treatments, as you may know, are for individuals who have mild cognitive impairment, perhaps have early dementia, needs to be of Alzheimer's type. There's a significant workup that's involved. So also in seniors clinic, it doesn't end up being sort of an active discussion. Nonetheless, we wanted to highlight, this is the work of Dr. Laura Mackey and others, where we've developed a few primary care pathways. I'm just going to show you a few screenshots to remind you that these are here, walking you through from when someone has cognitive concerns, thinking about how you can then, of course, do a thorough evaluation of depression, delirium, medications, functional status. And so these pathways continue to walk you through what is normal aging, and then a recommendation to do a mini-cog. If the mini-cog is abnormal, then to do, oh, that one didn't line up well, but to do a MoCA or a SLUMS, and to think about, like, are you then diagnosing such that you want to do further evaluation. The other pathway that exists is the dementia staging and management. We broke these into two because there is really a lot of content. And so you could even use this as a quick primer. Thinking about the different stages and how they can be divided based on the functional level that the person is at. And then there are recommendations for treatment, considerations of when you might think about referring to neuropsychology or neurology or other treatments. I know these are small, but they're here in the deck. Let's see if this will play. One of the other aspects that we know, actually this year's emphasis is on annual wellness visits and increasing the quality and quantity and appropriateness of use for the annual wellness visits. Within that is also a cognitive assessment. Through some of the work that we've been contracted to do with Colorado Department of Public Health and Environment and that Colorado state plan is to build an e-learning module. And this is one of the sections and a specific emphasis of leveraging the annual wellness visit to be able to incorporate in cognitive assessment in a brief way.
Cognitive impairment is common and increases with age. Your patients may be having memory or thinking changes. They may be afraid to bring it up with you because of fear or stigma. Less than half of older adults experiencing memory issues talked with their doctor about their concerns. Primary care teams can use the annual wellness visit to screen for cognitive changes and support early diagnosis of dementia. The first step is to recognize that dementia is under-recognized in primary care. The goal is to detect cognitive changes that are affecting daily function. Here are practical tips to enhance the cognitive screen in the annual wellness visit. Ask about cognitive impairment. Use direct observation and consider a pre-screening test. The cognitive screening can be done by any team member, like a medical assistant. Start by asking, have you experienced confusion or memory loss that is happening more often or is getting worse? If someone close to them is available, ask if they have concerns about memory or thinking changes. a team member can conduct a brief assessment, such as the mini-cog. Remember, the annual wellness visit also asks about function, including activities of daily living. By the end of the annual wellness visit, the goal of the cognitive screening is to detect whether the patient has abnormal cognitive impairment and needs further evaluation. If there are memory or thinking issues, the next step is to schedule a clinic visit for a detailed assessment of memory concerns. The value of early detection of dementia is clear. Improving your ability to detect cognitive changes in the annual wellness visit supports comprehensive assessments, earlier diagnosis of dementia, and helps older adults get the care they need.
All right, good. Okay, this works. So for those of your practices who may want to spend a little bit more time doing a bit of a deeper dive around how can we have a concrete assurance that we're doing a cognitive assessment in the context of the annual wellness visit, the Alzheimer's Association has put together this pathway. I've left the website as part of the slides, and this is also integrated into the CUE learning module, but it gives us a little bit of tangible aspects of how we could do a brief screen and then connect it to further assessment. This slide I'll also put at the very end of my talk, but for the CUE learning module, it's now available. We launched it on November 1st, so this QR code is live, and I'm happy to circulate a flyer with the way to register for free, as well as use the login code, and there are 2 AAFP CME credits available. So we're excited about the opportunity to disseminate this across Colorado primary care practices through AHEC and other networks, and then also nationally as we sort of adapt out the Colorado information, but hope to improve risk reduction, early detection, and also caregiver support, which I'll start to transition into. So after we've diagnosed someone, then it feels like this big challenge, which of course it is, to think about, well, what resources, tips, tools, or programs might exist that might be able to be of benefit to patients and their care partners. And this has increasingly been the focus of our work. We're really trying to seek patient and care partner input to refine our systems, especially in the context of the healthcare system, to ultimately improve patient and care partner outcomes. One of the ways we did this was through funding from the NIA Impact Collaboratory. And I'm going to show another video that gives sort of a researchy perspective of our approach to what we consider pragmatic trials. We know that it's not going to be sort of efficient or possible or even desired to participate in a traditional randomized controlled trial because care partners are often so overwhelmed. There are a number of barriers. So I will show you this video that summarizes some of the work we did with CT Lin and others to think about how we could build systems here at UC Health.
Hi, I'm Dr. Hilary Lum. At UC Health, we're committed to being extraordinary partners in dementia. This video shares the story of our one-year journey preparing to conduct real-world clinical research to improve dementia care. We believe in improving the quality of dementia care begins with understanding patient and care partner experiences. I'm so thankful to our patients and family care partners, UC Health clinical partners, and the Healthcare Systems Scholar Program. Our goal is to improve communication and care communication in dementia care through useful health information tools like a healthcare portal. We used 3 strategies. Strategy 1, we wanted to understand the needs of patients and care partners. We convened a group called Memory Research Partners Caring Through Technology, or Memory Tech Council for short. The Memory Tech Council includes 18 patients and care partners from diverse backgrounds. They have experiences with healthcare, caregiving, and being a patient themselves. The group discussed their needs and brainstormed how the healthcare portal could help persons with dementia and their care partners. Strategy 2. We wanted to understand the priorities of UC Health leaders. We asked healthcare leaders and clinical partners about what was important for quality dementia care. We asked how UC Health's strengths could help improve dementia care. We discussed what would be needed to conduct research and how it could potentially add value to the health system. Strategy 3. We worked early and often with health information technology colleagues. We wouldn't have been successful without this close partnership and are excited about the new digital tools that were built. Using these 3 strategies, we developed 3 tools. Tool number 1 is a change to an e-check-in questionnaire. Patients can complete 3 questions through the healthcare portal before a clinic visit. Working with the Memory Tech Council, we added a new question. The new question allows family caregivers who may be completing the questions to identify themselves. The goal is to increase caregiver involvement in clinic visits. Our next step is to evaluate how patients and care partners use the questions and discuss other options to support caregiver communication. Tool number 2 is a list of all UC Health patients who have dementia, which we call a dementia registry. Through discussions with UC Health leadership, we saw a need for and implemented the registry. The registry can be used by the healthcare team to more easily see which patients may have memory issues or dementia. Our next steps are to help clinicians and researchers at UC Health use this tool to offer better care for persons with dementia. Tool number 3 is a brief survey that asks family caregivers to provide feedback on quality of dementia care. For example, caregivers will be able to provide input on the care their loved one is receiving. Our next step is to design studies where these surveys can be sent to caregivers. We're excited to share these advancements. We want to thank all our Memory Tech Council members, colleagues, and the Impact Collaboratories Healthcare Systems Scholar Program for being important partners. We're looking forward to a long future of research and partnering with UC Health to improve dementia care. Hi, I'm
So that was in 2022. We finished it up in early 2023. So I'm able to give you some updates on some of the work that we've been doing, and also want to make it a little practical and tangible to what's available to you in your clinic. So I'll share some information about the Dementia Registry. In terms of implementation, I've already showed you about the primary care cognitive assessment pathways, and I'll give you more details about the outcomes, because these are available in My Health Connection and therefore available to you. So just a little bit more about the Dementia Registry or the dementia algorithm. This does exist across UC Health, and I'm happy to follow up with anyone who'd like to be able to use it, access it. As an example, in Seniors Clinic, we have about 4,200 patients with an average age of 82. 86% have an activated patient portal account, and based on the dementia algorithm, we have almost 600 individuals who show up on our algorithm. Our algorithm is designed to be a broader umbrella. It can include mild cognitive impairment and dementia. So I'll show you some numbers in a little bit related to some of our primary care clinics. I wanted to just highlight a little bit about the measurement of dementia care quality. So in the context of now the caregiver voice study is what we're calling it, in case you have any care partners who might be interested in participating, we are asking them a number of surveys, and the domains are listed here. An example of the survey in paper form is shown on the right, but it's also as a questionnaire that can be sent by a My Health Connection message to a person with dementia where we know that their care partner is accessing the account, or to the care partner's account. When we think about dementia care quality, this survey is asking them, this measure is asking care partners to reflect on, in the past year, has someone in the healthcare system asked about memory, daily activities, mood, concerning behaviors, and have you received advice on how to handle memory or behavior changes, what to expect related to the future in dementia. So how well are we doing with anticipatory guidance? Have you received advice about safety concerns, patients driving, or advanced care planning or palliative care? So I think this measure, which is used in a large implementation study led by David Rubin, is an example of, on a practical level, in primary care, when someone has a diagnosis of dementia, what are some of the goals and what's on my agenda for what I hope to be addressing and seeing if there are unmet needs. This is just a schematic of the current study that we're doing, representing that we are enrolling 200 individuals with who are care partners of individuals with dementia. They participate in telephone surveys, and it'll give us feedback on the validity, the psychometrics of this care partner related measure. This is the QR code for the study. If you have any partners who might be interested, and we're happy to follow up, I'm also happy to share or speak more about this. So care partner support and community resources. I know that this is sometimes feels like it's a black box, and I'm very excited about where we'll end today with, I think, some exciting aspects from Medicare that are on the horizon that I hope we'll be able to participate in to offer to our patients. So I'll say a little bit just about some of the work that I think all of us can do in terms of improving communication when we have a patient and their care partner, including when they're communicating with us through the patient portal. Some of you may have coached your patients, or they may naturally know to already sign their patient portal messages with their name so that you know who you're communicating with. But more often than not, you may not actually know who you're communicating with, or there may be multiple people. And I think that introduces ambiguity and can be very tricky, especially when multiple of us on the care team are communicating with more than one person supporting the patient and who's involved in care. So this was nuanced in the video, or introduced in the video. Many of you likely are familiar with our notes. That's the 2 questions that are sent ahead of a visit with you, that then if your dot phrase pipes it in, or if your template note already has them pre-populated, you have a perspective of what the key updates and questions are you as you go into the visit. Within seniors clinic, especially given our high population of individuals with dementia and high care partner engagement, and yet still the uncertainty of who's actually completing the message, we wanted to pilot a self-identification question. And here's sort of what that looks like. So we added the question on the left, which of these applies to you? And individuals had branching opportunity to select that they were the patient, they were someone helping the patient, or they were not the patient. In a future version, we will actually update these words to be even more patient and care partner centered. The 2 agenda setting questions still exist. What are updates? What are questions you have for the visit? But as far as we know, this is the first time a demonstration of will care partners self-identify so that they can have more self-efficacy in the visit, and they can acknowledge that the agenda that they're entering in comes from their perspective. So just some data. We have run this in seniors clinic since May of 2022. In October, we looked at a number of charts. We looked at 503 charts, saw that about a third are even using our notes. So these are all people who have My Health Connection. About a third complete our notes. And then within that third, about 31% are someone other than the patient. Patient with help, or someone not the patient. And the pie graph on the very far right shows that there's a range of individuals who help. Could be adult children, could be spouses, could be someone else. We're also starting some analysis to look at various topics that come up in these agenda setting notes. And I think, bigger picture, why this matters is because as you're receiving either small updates or substantial concerns within those our note agenda setting, it matters who's sending it, we argue, and that what people are feeling comfortable submitting to us in clinic may vary by whether they're the patient speaking for themselves or if it's perhaps in the context of dementia where there's a care partner helping. So we did see some differences in symptoms. The darker blue bar is when it's someone not the patient, and yet there's also some commonality of topics that the individuals submitting feel comfortable raising. One key topic area that of course differs is memory-related concerns or dementia-specific questions. Those come up much more frequently when a care partner is the one submitting the note. And part of our next steps are to think about how can we link what's said in our notes to additional resources via Livy, as well as other aspects of the patient portal. So from a research perspective, this is how we sort of put things together. This is a framework that adapts a SEEPS model as well as relational coordination theory. So SEEPS is a systems approach thinking about how work systems can then support work processes, especially with teams, to lead to work outcomes. And so it's helpful for us to just think about like, why might a technology or tool with a task like our notes and like a care partner's ability to self-identify ultimately help improve work outcomes like patient care, patient satisfaction with communication, a sense of alignment, a sense of being heard. So we're continuing to sort of have this model evolve to think about how small nudges that we might do through the patient portal can ultimately help us have clarity as we're setting agendas and as we're thinking about what does the person with dementia need, what does the care partner need, how can we align them with resources. This is another model where we think about different types of consumer health information technology or different aspects of how could the portal be leveraged to do some of the things that can be automated. You know, if there's a question about falls, might there then be a way to detect that in it using natural language processing to connect them to a CDC-based study class or a community-based exercise class so that we can provide some information and then as a next step and always a wraparound, the clinical team provides additional tailored information. We're also thinking about this from a medication perspective. If there are questions, say antipsychotics come up in the medications, you know, is there a need, an opportunity for specific education that can happen? So that was a little bit of an overview of different care partner research that we're currently doing, especially within the patient portal. Now I wanted to give next steps and current resources related to connecting to community things. For those of you that may have been at the Society of General Internal Medicine meeting that happened recently, you may have seen two of our residents, Thais and Ellie, present on their work related to helping us to build out additional resources for dementia care, especially for Latino caregivers of individuals with dementia. So in the context of UC Health, we have a Alzheimer's and palliative care study that if any of you also attend, you may have seen some of your patients with dementia who have been admitted also be part of what we call the ADRD palliative care study. Part of that study is a resource guide to really try to help put into the hands of care partners some local dementia resources that are helpful to them. As we've worked on the adaptation, you can see an example here of how we have the contents in English and then also in Spanish. Behind the scenes, Thais and Ellie have done the important work of contacting over 70 organizations to find out, do they have capacity? What does that look like in terms of bilingual staff, cultural knowledge, adaptation and experience? So we're really trying to highlight in this guide that resources are available if an individual speaks Spanish and that's their preferred language. Thais and Ellie are also doing a lot of interviews with individuals who are Latino caregivers to understand the current barriers and challenges that they're facing. Here's some of that feedback. So there are Latino caregiver struggles. One quote, "It's getting hard to care for my parents. I have to do everything. I bathe them. I help. I still need to go to work. There is no one here to help me." Another said, "A nurse came but didn't speak Spanish." So that is where we're trying to have this intentionality of recommending resources that have Spanish-speaking staff. Also, in even just approaching the fact that this resource guide exists, one said, "I've never received a resource guide like this one. I've received some related to elders, but not specific to dementia care." So I think we're right that it's generally hidden to be able to find dementia-specific resources. We're happy to share out this guide. We're always iterating it. We have it available as a PDF, and we also have various dot phrases that might be things that you can edit out of, and use in your after visit summary of specific resources. Our seniors clinic social worker also meets regularly with other social workers and is happy to be a resource. Another piece of innovation that I just wanted to highlight, you may see some various nudge clinical trials that we may do in the future. UC Health is investing a lot of resources into Livy. Perhaps you've seen an example where individuals who are interested in stopping smoking have participated in a tobacco cessation process mediated or moderated through Livy chatbot, where there's some interaction and motivational interviewing. So one of our current steps is we've built in dementia and memory and thinking resources so that if a person with dementia or a care partner has questions about dementia or memory, they can also use the public site. A next step I've heard that is possible is that within this memory skill in Livy, there's a way then for individuals to express that they have a question that they'd like follow-up from a team member. So where Livy is starting to have capacity to allow us to sort of close the loop, that it doesn't just have to be a care partner looking for information, but that they could then reach out to a team for follow-up. So then, who would do that centralized follow-up, you ask? We are excited about the Living with Dementia Caregiver Support Program, which has currently been in seniors clinics since 2018. We've served 175 dyads where we provide longitudinal monthly phone calls specific to dementia caregiver support, education, training, coaching, that's really highly specialized. When someone knows that they're really living the reality that dementia care is hard, and this care team navigator ends up in some ways being like a friend on the inside to help navigate the complexities of coordinating care within our health system, but also wondering about how to find so many different community resources and how to try new ones when the one that you thought might help actually wasn't a good fit. So that's been the Living with Dementia Caregiver Support Program. Earlier in January of this year, we were able to expand it to 8 clinics, which includes our internal medicine clinics. So there are currently 62 individuals who are enrolled in this pragmatic trial. So everyone enrolled receives the caregiver support program, which is called Care Ecosystem. And we provide this monthly follow-up. We do a 6 and 12-month assessment, and we'll do behind the scenes propensity matching to look at control participants who are in our system but are not enrolled in the program. So that's enrolling for the next year or so, or till April of next year. And then I'm very excited about the future state, the CMS guide model. Before I tell you much about that, I told you that we've run the dementia algorithm within each of our internal medicine clinics, and you can see the number of individuals who show up on the algorithm for each of the listed clinics. So it's not a large number of people. Lowry Internal Medicine, there are 114 patients currently on the list. We also know that this is an underrepresentation, underestimate, because there's an underdiagnosis. In a future state also, there is an algorithm that uses health system data to identify individuals who are not yet diagnosed, but have a high probability of having a diagnosis of dementia. That's called E-radar from a colleague at UCSF. So there are tools from big data perspectives that could then nudge us as clinicians to think about, should we do a full cognitive assessment, because might there be dementia affecting this person? So here are some of the numbers of current state. And it's interesting to reflect on these, because in any number of your own panels, you may only have less than 10 individuals, maybe less than 5 individuals who have moderate or advanced dementia. And yet that's its own challenge, because these resources are not familiar to you. And it can feel like rebuilding the wheel and wanting to know who can help over and over again. So the GUIDE program. CMS introduced this a few months ago. This is the first time Medicare will reimburse healthcare systems to provide caregiver support. The VA has been doing it for years, sort of. It has the VA caregiver program, which is very important. I always screen, are you a veteran? Because the VA has excellent wraparound services for older, vulnerable adults, including a VA caregiver program. But this is the first time that Medicare will reimburse programs that are set up to provide dementia caregiver support. We've, as UC Health, submitted a letter of interest. We're waiting for the application to be released, and we hope to be able to apply to set up this program. Just briefly about the program, and these slides are thanks to Chelsea Ganger and the CU Medicine team. The goal will be to, again, provide longitudinal care management that is specific to dementia care and caregiver support, with the aims of improving quality of life, reducing healthcare utilization, reducing strain on unpaid caregivers. One of the actual survey measures is the Zaret Caregiver Burden Scale. So for the first time, they're actually measuring what does the outcome of the caregiver look like. The eligibility criteria are listed here. Dementia diagnosis, enrolled in traditional Medicare, so cannot be fee-for-service, and not living in a specific setting. They need to be living at home or assisted living. So independent and assisted will be fine. As we think about this program, I think there's lots of opportunity to think about how could we set it up at UC Health so that it is certainly aligned with the GUIDE program, and then also able to be offered to individuals who don't specifically meet these insurance criteria. This slide is small, but it outlines the key program components and just describes the interdisciplinary approach. The pharmacists in each of our clinics have been doing a tremendous job as part of the Living with Dementia program and Care Ecosystem program in helping to provide a thorough assessment of, are any medications impairing cognition, and then also might there be appropriateness of using donepezil, memantine, or other medications that are approved for dementia. One of the interesting aspects of the program is that it includes a $2,500 respite benefit. So it just sort of emphasizes the importance of focusing on caregiver needs that this program will offer. I think when we have this program here available to our patients, I think this will be a next step in encouraging us how we can organize our knowledge of caregiver resources. In many ways, I haven't even talked about the elephant in the room, which is how hard caregiver support is. And that's because it is really disorganized. There are many different pairs, there are many different parties. It's costly. It's not available to this in the same way to all the same people. So this program, I think, is designed well to help us have a systematic and comprehensive and longitudinal approach that hopefully provides centralized support for many of the aspects of where dementia care is hard. And so I'll end with this slide, just taking us back to the aspects that I've walked us through, from risk reduction to early detection, thinking about what dementia care quality can look like and aligning with what matters, how we can think about increasing supportive engagement, especially or starting with even understanding the agenda of 2 different people when they come into our clinic visits, and then thinking about resources that we hope to grow over time, both in awareness of resources, but then of structured processes so that we can help connect patients and care partners to community-based resources. And with that, I'll leave this slide up here, but I'll take any questions. Thank you.
Like, there are a lot of families that are there's the family. And so much care is not as like, right now, effort is where is that money going to come from? And so it's like what families need anytime that very low for where any thought of where that money or robots or anything where that comes from like that. Where
Yeah, thanks for the question. For those on Zoom, I'll repeat it. Essentially, the question is, when individuals especially have moderate to advanced dementia and there's need for more hands-on caregiving support and the family caregiver is overwhelmed, needs more help, where does that come from? And I hear in that a workforce question, a money question, and even just how things can be organized. How can we do better? That, I think, is the most challenging policy question in arguably in healthcare, depending on what your perspective is, but certainly for geriatrics and older adults and in dementia, that question is our hardest one. Specific to the GUIDE model and the $2,500 respite credit, which will go to the family, I think Medicare is anticipating that that money comes because of cost savings by reducing ED visits and hospital stays. So the GUIDE model will have as a metric total cost of care in the same way that primary care first does, at least for tier 3. So I think that's one aspect of why Medicare's demonstration model and the GUIDE model needs to be fee for service, is because they really need to be able to do all of their accounting. So that's just a partial question. We also know $2,500 over the course of a year for respite is nothing. I mean, it's just nothing. And you made a great point of who also are the agencies, who can be paid, who are the friends and family who have availability and training and expertise to be able to safely provide reliable, trustworthy care. So there's also absolutely a workforce challenge. I don't think we are close to making this problem better. I think it's still a number of years away. And the hardest part of that is that it means all of the burden remains on the family member. And I think our role as primary care is just to acknowledge that every time and ask, is there something more that we could help, and exploring what has worked, and encouraging them, it's okay to reach out. From a technology perspective, you also raised that in your question, are there going to be some applications of technology that could perhaps reduce the challenge? This past weekend, I learned about a company and an app called IANA Care. IANA stands for I Am Not Alone. And so this woman, Jessica Kim, developed an app, which is essentially a way of putting your need onto the app and within a community, allowing it to be responded to. Because it's even that burden of asking for help. So a small technology example of how there are so many different burdens that a care partner is just navigating each day. Mark. Yes, Medicaid has many more services. The question is, what does Medicaid pay for along the long-term care services and supports? I think one challenge is that it's highly variable state to state because Medicaid is state to state, and yet there are great emerging models, including medical foster home, where if someone is a Medicaid beneficiary, they could live in a home-like setting if they didn't have a family caregiver who was able to provide that care. Medical foster home is one example. Just in general here in Colorado, Medicaid does pay for non-skilled support for personal care providers. And in seniors clinic, we have advocated and asked, we fill out our information such that individuals can often receive 20 to 40 hours of additional support paid for by Medicaid. So it's paperwork for us on the clinical side. There's an approval process, but that is an effort for Medicaid either to pay agency staff, or also here in Colorado, the caregiver themselves can be paid through Medicaid. Medicaid also enables people to be eligible for the program of all-inclusive care of the elderly, which is InnovAge here in our area. We may have less knowledge of it locally because, of course, once someone signs up for InnovAge, you are no longer their primary care clinician. So I think that just ends up being a knowledge barrier. So I think those are some examples of how Medicaid, especially in certain states, has been more innovative in being able to support long-term care needs. I don't know if there are any questions on Zoom. Yeah. The first one, thanks for the question about the algorithm versus the registry. They are actually the same. The algorithm and the registry are the same. I've started to use the word algorithm more. What are your thoughts on adapting the Yeah, I think the question about how could any of these interventions serve the needs of out-of-town care partners? And I actually think many of them can. A patient portal, shared access can be given to trusted individuals who may live anywhere. I have access to my parents' portal. They live in Virginia. And that's an example of where it can provide access across areas. And then I think the guide model, the care partner does not need to live locally. So a care partner could be coordinating care, which is its own challenge. And there could absolutely be support for that care partner's role, because the number of things that care partners are doing is so varied, including supportive or surrogate decision-making, which absolutely, as we know, happens across state lines. And so I'm glad the guide model is telephonic, and it really allows flexibility that the care partner could live wherever they live. These programs may offer patients with intellectual disabilities. Yes, so if, so far, not, but in the future, absolutely possible. So I do think that the guide model, if someone is 65 and with Medicare fee-for-service, regardless of why they have dementia, including if it's Down syndrome, they can. But to the broader question of intellectual disabilities, that's not been specifically incorporated into the guide model. You mentioned lower blood pressure target patients. Yeah, thanks for the question about the Sprint Mind data in terms of blood pressure targets. For younger individuals with blood pressure, so to age 50 or over, compared to if they are somewhat older, I'll admit, in geriatrics, because our average age is 82, and you have to be 75 to be in our clinic, I tend to use a lot of additional input of what is the best blood pressure target, not just treating to the lowest possible number, because the risk of falls, fatigue, dizziness, unsteadiness also is increasing. So I tend to be less aggressive, even when individuals have mild cognitive impairment in their 70s. I'm often really leaning into exercise and social engagement, because I find that some older adults with mild cognitive impairment are just having smaller circles. And I think that is really challenging for them. Yes, great question. For the Sprint Mind trial, which I think is a great Journal Club article, because it was really a complex design. So the question was, for those, did there end up being a selection bias? Because if you could tolerate having your blood pressure down to 120, you're a different type of person. Their protocol was, I think, up to 3 tries to get you down to 120. So even if it was, if you had trouble tolerating it, they still asked you to hang in there to get there.
The caregiver's guide, I'd love to share.
Yeah, I will send the dementia resource guide to you, and it can be shared out to whoever. Thanks so much.